like to welcome everybody to breakout room 5. We are the Medical Student Education and Research Focus Group. So Megan Yee is our first presenter today. Megan, can you turn on your video and try sharing your content for us?
Can you see my screen?
Yep, I can see it and you sound great. So go ahead and get started.
All right. Hi, my name is Megan Yee, and today I'll be presenting on the analysis of the focus group results for teleophthalmology to improve eye health among Latinos study. So currently, many telemedicine studies in literature are performed in a clinical setting, which is why our study wanted to look at the effects of bringing teleophthalmology screenings into the community. So our screenings were done at United Community Center, or UCC, and this is a Latino community center based in Milwaukee. And here participants were screened for diabetic retinopathy and other diabetic eye diseases. My poster will specifically highlight the focus groups that were performed at UCC and before and after the screening intervention. So our aims were to, 1, ascertain the attitudes and knowledge of urban Latinos in Milwaukee about diabetic eye disease and telemedicine, and 2, to assess their response to teleophthalmology screenings at a community center facilitated by the Spanish-speaking involved in every step of the research project, from writing the grant to the study protocol. A retinal imaging camera was stationed at UCC, and staff members were trained on how to take the images that were eventually sent and reviewed by an MCW team. And the UCC staff was also involved in creating the focus group questions and facilitating the focus groups. So our focus groups were held in both English and Spanish in order to account for any differences in acculturation levels and health beliefs of English and Spanish speaking Latinos. In the top right corner of results is our sample size. And the main question that we had, so 100% of the post-screening focus group participants who underwent the screening at UCC responded positively. And 3 main factors that were mentioned were location preference, trust in staff, and comfort speaking Spanish. So participants mostly mentioned that they liked being in their own environment, not having to travel far, and being surrounded by their community. And some reasons why participants did not prefer going to the local hospital, which was Freighter in this case, was because of the size of the campus, not knowing the staff or the area, not being able to speak Spanish, and having to travel a farther distance. So we assessed baseline diabetic eye disease knowledge using the National Eye Institute's IQ test. These were the scores of both the English and Spanish pre-screening focus groups, so it was both low in both of them. And in both groups, there was a question that everyone in that group answered incorrectly. So in the Spanish focus group, it was people who have good control of their diabetes are not at risk for diabetic eye disease. And in the English group, it was diabetic eye disease usually has early warning signs. So both of these are false. And this just shows the gap in knowledge amongst the participants, and also can explain why. So at the bottom here, why when we asked about attitudes towards diabetic eye disease and seeking care, emphasis or a poor emphasis on preventative care was mentioned by the participants. So one participant even said, if my relative didn't have diabetes, she might not have had an eye exam until she was losing her sight, because only when you feel the problem is when you do something. We also, a lot of the participants did not know what telemedicine was before the study. So after it was explained to them, their perceived pros were efficiency, convenience, not needing transportation, and early disease detection, whereas their perceived cons were loss of physician-patient relationship, potential additional costs, and initial fear of technology. Lastly, we were also interested on how to raise awareness of diabetic eye health within the Latino community. And an interesting theme that came up was the use of the concept of family as a means of health promotion. And so some examples that participants said were having a video that showcases a multi-generational single household affected by diabetic eye disease, with the emphasis on making material that is relevant and pertinent to the audience, and also teaching children in school more about diabetes so that when they go home, they can teach their parents and their grandparents about it. So that just shows the use of family for health education and also influencing healthy behaviors. And lastly, to sum up the effects of bringing teleophthalmology screenings to UCC, one participant said, "If there was something here at UCC, even though I feel like I don't need it, I never had it, I would completely do it. It makes it so easy, convenience." So I think this just shows that bringing resources to the community can increase health promotion and also participation in studies when there's community involvement in the creation of this intervention. So overall, we think that high acceptance of this novel teleophthalmology approach may help improve compliance to the annual screenings in the urban Latino communities. Thank you.
Awesome. Thanks so much, Megan. Again, if anybody has any questions for our speaker, feel free to throw them in the chat. I can ask you a quick question. So again, I think this, connection with sort of changing that mindset of preventive care mixed with the convenience is so important. Are there other services that the clinic's looking at offering? And again, is this screening continuing to occur even after you finish the project?
So what this project found was that it is feasible to do screenings outside of a clinical setting, so in the community. So the next step of the project was to bring this teleophthalmology screenings into a community pharmacy. It's called Hyatt Pharmacy in Milwaukee. So we found that there's more people that you can reach in outside of just the community center, but still in the community. So that's the next step of the project. And sorry, what was the other question?
Whether or not the clinic is exploring any other preventive care screenings or others kind of similar projects.
I think for our research group, it was mostly focused on diabetic retinopathy and the eye, but UCC seems pretty proactive in finding other interventions or studies and resources for their community members. So I'm sure there probably is more.
And then there's one question in the chat too. Do you think that this could be adapted for use in a homeless shelter?
Yeah, I definitely think this could be adapted. It's all about partnering with the staff at whatever location, making sure you teach them how to use the diabetic retinopathy camera, and just making sure there's open communication and collaborating. But I think this could definitely be adapted in different settings, like a homeless shelter.
Great. Well, thanks, Megan. We'll move to our next speaker, which is Katerina Tori.
Hello, can you hear me?
I can hear you. Great. Do you want to try sharing your content? Oh yeah, people were finding the reaction feature that you can give her a round of applause.
Okay.
And yep, that looks great, Katerina. The sharing's working well, but she won't be able to have a video feature, but that's fine. We can all hear you well.
Okay, great. I can get going then. Hello, everybody. My name is Katerina. I am a second-year medical student here at MCW, and I am a part of this student-led program called Checkup, which is effectively working to improve outcomes and health knowledge with take-home health educational materials for our patients, and then to further improve in-person education of healthcare providers. In our case, we are mainly providing education on our medical students at MCW on different topics across the board that we have seen have a greater need for prevention. We have seen from the literature that lack of disease prevention and daily management education is seen in all patient populations, but is most prevalent in underserved populations. Unfortunately, direct patient education is not the only most prevalent in underserved populations, but direct patient education to our healthcare providers has been said by majority of residents and young physicians to be inadequate. And so we are trying to address disease prevention and daily management of chronic illnesses. And this particular project is looking at addressing disease prevention and management of, in general, of common ophthalmology issues. The way we would get started, and this is in the very first steps. So here we only present the idea of our project. But what we are intending to do is we have created a Qualtrics survey that we are going to disseminate across primary care physicians, emergency medicine doctors, internal medicine doctors in our entire system at MCW, in order to ask them how confident they feel in their skills to evaluate their patients when they appear to them, in terms of any eye condition that they might have when considering the common ones: conjunctivitis, diabetic retinopathy, age-related macular degeneration, glaucoma, diabetic retinopathy. Importantly, what we care most is we know those diagnoses will be made by an ophthalmologist, but we care to see if our PCP is going to be able to follow up and make sure that the patients are compliant with their regimens, they are not experiencing any additional problems. The methods, therefore, is a Qualtrics survey that we are going to send, like I said, and the questions you can see in the figure 1 here, where we have some sample questions of the needs assessment survey we are going to perform. The questions are Likert scale types, and they're aimed to assess the level of comfort with basic eye exam techniques, triaging, diagnosing, treating ocular disorders and injuries, and educating patients on prevention and management of common eye conditions. In terms of the results that we expect to find based on the literature, we do anticipate that there is going to be some discomfort among general practitioners in basic eye exam techniques, triaging, diagnosing, and treating ophthalmic conditions. And we are not so sure how much of that is going to be based on how much of the equipment is actually available to primary care physicians in the clinic, or how much is related to their medical school knowledge and how much of that wasn't there when they would have wanted it. So we do anticipate that current physicians and students will indicate need for increased ophthalmic education and medical training, and we expect the need for continued education on referral recommendations to ophthalmology. Once we get the responses from the physicians as to what they feel most comfortable with and what they wish they had learned more about in medical school, we are going to go back and create a workshop for our first-year medical students, where we are going to be working with the ophthalmology department and teaching them how to best diagnose, screen, prevent, treat, and educate patients on some of the most common conditions they might see on clinic settings like the Saturday clinic for the uninsured. Ophthalmic medical education is a cornerstone to improving eye health care in the general population. So this project is engaging the physician and the student community to understand if more training is needed to equip medical students to have a formative impact on patient-engaged education for ophthalmic conditions. And I think that's it for me. Hello?
Thank you, Katerina. Again, feel free to add any questions in the chat. As you may or may not know, I'm up on the central Wisconsin campus, so I'm curious whether or not you've tried to reach out to either of the regional campuses to do these workshops or do any of your surveys.
So we haven't yet sent it out. It's in the IRB approval process right now. And once we do disseminate it, it's really going to depend on MCW where they allow us to send it, if it's going to be just allowed to the Milwaukee campus or all the other campuses. But that would be totally fine with us.
Yeah, well, feel free to reach out if you do think that that would be interesting and helpful to provide some additional survey information.
Thank you.
At this point, I'm not seeing any more questions, but let's all do our reaction and give you a round of applause for your presentation. And then our next presenter on the list, I believe, is Allison Whorton. Are you here and able to turn on your camera and share your poster?
Hello, I'm here and
Awesome.
I am joined by a partner that will.
Even better.
Yes, and let me.
Yeah, as she gets going, hi, I'm Spenser. I'm one of the managers at the Saturday clinic with Allison.
Yes, and we're second year medical students, and I'm also a current manager at the Saturday Clinic.
Yeah.
Wow.
So,
I'd say welcome, and you guys can go ahead and take it away.
yeah. So when COVID was first reported in Milwaukee, I think it became pretty clear to those of us at the Saturday Clinic that things would not be how they used to be for a while. And so we responded by doing a lot of telemedicine in partnership with the family medicine clerkship. But this poster is really going to focus more on how we adapted that work to bring this to our student volunteers and think about longer term implementation beyond just what we were doing in April and May. So the first figure that I'd like to talk about is the one with our total number of appointments. So as you can see, we've had a pretty significant drop off in in-person visits due to COVID. That's was very intentional on our part, but you'll notice we've actually had like an increase over 2019, and a lot of that's due to the telemedicine visits we've been able to offer. You'll see about 57% of all of our appointments since July have been by telemedicine. And so that's just allowed us to increase despite the pandemic and give more flexibility in appointment times and let patients stay at home and do appointments as well. So it's definitely affected how we deliver care, but also how we have students engage with underserved patients in clinics. I'll let Allison speak to that.
So then health during COVID, but when we invited 94, when we had 94 applicants from our second year medical school class, you can see that 26 of them were interested only in the telemedicine program. And of those 26, 11 were brand new applicants to our Saturday clinic, compared to only 4 new applicants to the in-person volunteerism. So that suggested to us that our summer pilot program was successful in spreading the word about telemedicine and increasing interest among our students. So right now we've been working with 42 medical students, and we just sent out a survey for feedback. And in figure 4, using the Likert scale, we asked them to determine what their comfort was completing a patient interview before starting the program versus after the program. And you can see that there was a significant increase in their comfort level after starting the program compared to before. We also collected some qualitative data, which you can see to the right there, and highlighted are some successes and challenges from the program according to our volunteers and some direct quotes from them. But overall, we can conclude that the students believe that the SCU telemedicine experience has enhanced their medical training. And this is good for us because, you know, SCU, one of our main objectives for students. And this program has also allowed us to potentially increase the clinic's capacity to provide care. So this on top of preliminary data that suggests that the telemedicine volunteers are able to complete more appointments than their in-person volunteer counterparts, suggests that this program is definitely here to stay here with SCU and will be beneficial not only to the community, but also to our student volunteers. And then back to Spenser for some future directions.
Yeah, so one of the things we want to do next is look at gathering some formal patient feedback. We do have one submitted survey done and sent into the IRB, but we're looking to explore that further and really think about how follow-up care works for patients at our clinic with telemedicine. We also then are going to be preparing new training and program information to generate M1 participation as we make a transition over the next few months. And then there will always be like continual, like iterative development of this program based off of feedback from our stakeholders.
And I think that's it. And now we can take any questions y'all might have.
Sounds good. Thanks for sharing your work. Feel free to put any questions in the chat. I guess I'm curious sort of how has the experience changed for students? What do you think students might be missing out on, you know, having to only do the telemedicine versus what they were experiencing pre-COVID with partnering at the student run free clinic?
Sure. So I think that they definitely just miss out on that in-person aspect, taking the vital signs, assessing the patient with your eyes, doing whatever examinations indicated after you do the interview. Since we do have our set volunteers for telemedicine and our set volunteers for in-person, it's very much one-sided for telemedicine right now. And that's just due to COVID.
Yeah, and I'd add you'd also lose a lot of that interprofessional work too, like with pharmacy and other different roles that you would see within a clinic. It's kind of you and the doctor and the patient. So.
Could I ask a question?
Yes.
Go ahead.
Go for it.
Hey, it's Brian Johnson. Thanks, you guys. This is such a cool project. I'm curious what kind of sense you have about the patient experience with this change. I know you mostly focused on the medical student experience here, but anything that you've heard just, even on a small scale about how patients are responding to this change.
I think it was definitely a relief, especially in the beginning when the lockdown started and they realized they could still get the medicines they needed and still receive the care they needed. So there's definitely that sense of appreciation. Of course, as we said in the future directions, we still want to develop a survey to actually get data, but it seems like they're grateful to have this opportunity to also decrease their risk. And since we're a Saturday clinic, normally, Saturday morning is that's all we have. But now they can reach us, right after work, they can complete a phone call. So I believe, and from some very informal feedback, it seems like they're appreciative.
So we do have an additional question in the chat here. So what are sort of the competencies, maybe the knowledge, skills, or attitudes that you think students emerge from being part of this experience?
I think an appreciation for everything that goes into care, right? So this was a quick turnaround to a type of clinical care that we are definitely not exposed to early on in our careers. I think there's an appreciation for the importance of barriers to care. So a lot of our volunteers experience phone numbers that are disconnected, or patients that are rushing to get off the phone because maybe they're busy, they're working longer than they thought they would. So I think it gives them a little bit more of insight into our patients' lives and realizing that there's a lot of difficulties to accessing care for especially our population. I don't know, Spencer, if you have any other thoughts on competencies.
Yeah, I think you did a nice job hitting some of the big ones that are relevant for our patients. And I think with new students, some of it's just, this is new. So kind of just reminding them just to do some thorough prep beforehand and use the resources we've provided. Is sometimes I think the biggest challenge we run into when I notice things are missed. Because yeah, as a first year, second year, this is interviewing a patient's a whole new thing. And so that can be a challenge.
Great. Well, let's give Allison and Spenser a clap, and then we'll transition next to Lucas Mathson.
There we go. Okay, my name is Lucas Mathson. I'm an M1. Actually, I'm at Milwaukee, but this presentation will be relevant for the MCW Central Wisconsin campus. I did an internship with them, and some of the other faculty and students are highlighted who have continued on some of that work. So the Medical College of Wisconsin expanded to a third campus located in Wausau, Wisconsin in 2016. This campus was modeled similarly to the Green Bay campus in that it actively involves the community, and it was designed to meet the physician shortage that's in northern Wisconsin. The school and its faculty are extensively interconnected with the local healthcare system, as well as the local community. Part of the student involvement with Central Wisconsin occurs through the Pathways course, Physician in the Community. The Physician in the Community course is an intricate part of the campus's accelerated curriculum. The students are given an opportunity to make partnerships with community members, as well as to develop scholarly projects designed to impact the local community. The course aims to help students gain a better understanding of the social determinants of health and how those determinants impact life in Central Wisconsin. The hope is that this focused education and the community connections will allow students to become effective community-based physicians that are equipped to meet the needs of Central Wisconsin as well as the surrounding rural communities. 3 years after its founding, the faculty wanted to get a better understanding of the impact of the school in Central Wisconsin, as well as to gain feedback about their relationships with community stakeholders. As a community health intern with AHEC, I conducted interviews with 31 of these community stakeholders. These interviews were focused on assessing the effect of the medical school on Central Wisconsin, as well as gaining feedback on what medical students gained by participating in the physician in the community pathway. So for the sake of this presentation, we will only be focusing on the feedback that's relevant to medical students and their education. The first important finding is that the stakeholders shared the views of the faculty that this physician in the community course was an excellent way to immerse students in the community, as well as to expose them to the challenges that face physicians who practice in a rural community. This perspective on community and patient-focused medical education was best summed up by a stakeholder who said, "I believe that it is so important that doctors understand the community, understand the culture of the community. They have to have their finger on the pulse." Another relevant finding that came out of these interviews was characteristics and themes that the stakeholders viewed as important for students to master while in medical school. The four most relevant character traits were perspective, trustworthiness, perseverance, and social intelligence. These traits were intertwined in conversations about communication skills and having physicians who understood how to connect with their patients. A quote that summarized the views on students gaining a perspective of these roles in the community was stated by a stakeholder who said, "I want them to be human beings, to know the human side, the art side of practicing medicine. It's not learning the Krebs cycle, it's learning the life cycle." With feedback about the desired traits and skills of future physicians, the faculty designed a community engagement feedback tool. This tool is used to help track students' progress throughout their time in the physician in the community course. Input for this tool is gathered from student self-assessments, faculty, as well as community project advisors. This tool provides a way for faculty to assess the growth of each student in the identified character traits of a community physician. It also presents a great way for students to be evaluated and to understand what areas they need to improve upon in their journey to becoming a community physician. The stakeholder interviews provided valuable feedback for MCW Central Wisconsin to assess its impact on the community and identify traits to emphasize in their physician in the community pathway. The community engagement feedback tool allows for quantifying the development of community engagement in medical students. It also enables faculty to evaluate the progress towards the traits identified to be important in a community physician. The demographics of the interviewed stakeholders showed limited diversity in categories such as race, education level, and socioeconomic status. A statistic from the demographic survey that was viewed as beneficial, however, was that nearly 50% of those who had interviewed had lived in Marathon County for at least 30 years. These stakeholders were able to give a great perspective on the changing needs of the community, as well as the impact that the medical school had had since its founding. Central Wisconsin is not home to a particularly diverse community. However, there is a significant Hmong population present, and efforts have been made by the school to better connect with the Hmong community through pathway projects done by students. And at this time, we can open things up to some questions.
Great, thank you, Lucas. I live and breathe this. I was Lucas's community mentor on this project, so we would appreciate any comments or questions from the audience about this work. Let's see, we've got one from Spenser here. It's, how has what you've learned from community stakeholders shaped how you've approached your medical education as an M1? And again, you're an M1 in Milwaukee, so I think it would be interesting to hear too what you feel like you've learned from that experience and how it's translatable even on the Milwaukee campus.
Yeah, so I mean, some of the things that weren't included in this poster that came from that interview were the stakeholders talking about how much they valued that person-to-person contact with their physician, things like eye contact, social intelligence, which we mentioned. So I think how it's impacted me just in the first semester is valuing the Foundations of Clinical Medicine course a lot and understanding how the patient interview is critical. And it's something that some people might not take quite as seriously, but understanding that that's your patient interaction and that can determine a lot of the relationship that you'll develop with your patients and how critical that is to that patient-physician relationship.
And I think something else that we talked about too, right, was we were also hearing from the community members how important it is for the students to be aware of kind of what some of those community resources are and how to address some of the social determinants of health. And you've seen even in the quality improvement pathway, you know, that kind of basis of the social determinants can really have a connection as well. All right, let's give Lucas a round of applause. And then next up, we've got, I think Brittany Schultz or Kristen Tischer. Is one of you on the line?
I'm here, Brittany.
Okay, awesome.
Share my screen.
Yeah, and if you've got your camera too, that would be great.
Definitely. There we go. All right. So as I mentioned, I'm Brittany Schultz. I am an M3 at the MCW Green Bay campus. My partner is unable to be here, so I'm presenting solo. Our research that we did in Wisconsin in general was a survey of Wisconsin physician gender bias. A little bit about gender bias on previous research that's been done in the past is over 70% of female physicians have reported experiencing gender bias at some point in their career. On average, they make less than $20,000 less than their male counterparts. Female physicians make up 1/3 of the working doctors, 46% of residents, and a good chunk of medical students, yet they, I'm sorry, I'm gonna move this here. Yet they hold a very small majority of leadership positions in medicine. Physician mothers have experienced gender bias and report that 90% of the discrimination was related negatively towards their pregnancy, maternity leave, or disrespectful comments about breastfeeding while they were on the job. And then in 2018, a survey of general surgery residents found that gender discrimination was reported by 31% of the residents, and 61% of those residents were female, and only 10% were men. I'm sorry, I'm trying to get used to my buttons here. I apologize. So the reason we wanted to look into Wisconsin physician gender bias was a group of us students had been talking about some experiences in our clerkships. And it seemed to be, the experiences that we had seemed to be very common amongst the females in the group. And the males in the group looked at us like, well, I've never experienced that before. So it kind of sparked our interest in, I wonder what other female physicians would have to say, or male physicians would have to say in Wisconsin. So our goal through this all was simply just to create a dialogue about it based on the results we found. How we did it is we sent out an electronic survey through the Wisconsin Medical Society's newsletter. So they have a monthly newsletter that went out. It went out, I think, 3 to 4 times within the year. And then the survey was completely optional. And then we had individuals select age, gender, their medical specialty, and location of practice, whether it was urban or rural. And then using a Likert scale, they had to answer 7 questions regarding their own personal experience with gender bias. And then my favorite part, which you'll see in a little bit, was they had the option to add in personal comments, stories, or opinions based on the survey or their own experience with gender bias. So there were 4 questions that we had asked that I thought were the most interesting. One of them was, I have experienced gender bias in the workplace. And the results that we found for this one that were pretty significant were 90% approximately 90% of the females who responded to the survey reported experiencing gender bias. And this was compared to only about 29 to 30% of the males who stated they experienced gender bias. So I thought that was interesting. This one wasn't as significant, but it was interesting nonetheless. We had them comment on whether they felt they have experienced disrespect from nursing staff or support staff. And as you can see, it's kind of across the board here. But one thing I thought was interesting was to kind of see the split between the majority of women felt that they had versus a good chunk of males felt that they hadn't. So here's another interesting one. So they commented on whether they felt that their pay or benefits are equivalent to their peers at the same level. And what we found was 65% of males felt that their pay was equal, whereas only about half of that, 33% of the females felt that their pay was equal. And then I have experienced, I have experienced gender bias in the workplace. So this is the same question that we asked, and then we just broke it down based on people who had responded in rural or urban settings. As you can see, there really was no difference. It does, whether you live in a rural area or practice in an urban area, both have experienced gender bias. So, all right. So like I said earlier, my favorite part of the whole project was reading the individual comments from people. So here's one of them from a female, age range 40 to 50, who practices family medicine. She stated, as a female physician, I'm constantly being assumed to be the nurse. Male patients have referred to me as sweetie and honey. Female internal medicine, age 60 plus. The gender bias over the course of my career was constant and pervasive. I am sure that I too am guilty of the bias. However, as much as I resisted it when I could see it, I know we all could do so much better. And then this one, I'm sorry, I'm having a hard time seeing the comment. You can see who it's from, but it says, one of my peers states that the reason there is a shortage of doctors in medicine is that there are too many women in medicine. He has done this on multiple occasions in front of me. A couple more. Gender bias exists primarily in the eyes of the individuals looking to be offended. Women in the past have worked less than men in ortho, thereby making less money. That's not bias. A physician cannot have it all. If one wishes to spend more time in a non-medical related activities, less money may be earned, period. And that was a male, 60 plus in orthopedics. And then this is a male and family physician or a family medicine, age 40 to 50. As a white male, if I've experienced gender bias, it would be in my favor. Most notably, my voice seems to be respected at meetings. So in conclusion, from what we found from the survey, we had 96 Wisconsin physicians respond to the survey, which doesn't seem like a lot, but I was actually really proud of it because like I said, it was an anonymous link in a survey that they had to actually go through the newsletter to find. So I was thankful for those 96 physicians. Only 17 of those 96 were male, 79 were female that responded. And I already talked about these numbers, but 90% of the females reported having experienced gender bias versus approximately 30% of the males. And then 65% of the men answered that their pay was equal to their colleagues, whereas approximately 34% of the females reported that their pay was equal. So one limitation of our study was we would have loved to see more male responses. Ideally, it would have been nice to see an even split between men and women, but it is what it is. So that's something that we could look into more in the future, is try to get more male responses. We felt that overall from the study that the survey did show that gender bias does exist, or that Wisconsin physicians feel it does exist. And we feel that the responses may indicate that there is gender bias in a larger scale within society. So it would be nice to put together some future studies to determine best ways that we as academic institutions and hospitals, all of us in medicine, can try to work together to eliminate gender bias in medicine. So, and that's just kind of an overall picture of what our poster looked like. Does anybody have any questions?
So unfortunately, we're a little low on time, so I'll have to cut you off there, but everybody make sure to give Brittany the round of applause. And feel free to reach out if you'd like to follow up with her at all on this really important topic. So thanks so much for sharing.
Thanks for
Well,
listening.
yeah, we'll move on next to, I think is it Ileana Sosa?
Yeah, Eliana, you got it right.
Awesome.
Alrighty, give me just a second to figure out how to share my screen. Oh, okay, I apologize. My computer is giving me a hard time about wanting to do this. Oh, okay. Let me see if this will work now. All right. Are you guys able to see that like full screen?
Yep, I can see it. It looks good.
Okay, sounds good. My computer is yelling at me because of trying to share. So, hi everybody. My name is Eliana. I'm a fourth year medical student here at MCW. And I worked with Dr. Moyer and Dr. Young to analyze the impacts of a service learning health education program on both public housing residents and medical student leaders. So to provide a little bit of background on our program, through kind of a literature review, we found that low-income populations and elderly adults have repeatedly been identified as some of the most at-risk groups for lower levels of health literacy, as well as lower or in poorer health outcomes in general. So to try to address this, MCW has been partnered with local social service organizations, initially Set Ministry, but later Lutheran Social Services, to try to address this issue. And so for over 10 years, we have kind of provided a health education program to the residents of Highland Gardens, which is a public housing apartment complex that predominantly serves elderly and disabled adults of minority backgrounds in the Milwaukee area. The program also serves as an opportunity for students to engage in community engaged scholarship as well. So as the program currently stands, MCW students, they plan, generate, and deliver monthly presentations on health topics that are selected by the residents of Highland Gardens. So our study had two primary goals. The first was to solicit Highland Garden resident feedback about the program to assess their motivations for participation. And the second was to assess any possible long-term impacts of participating in the program from a student perspective. I mean, we wanted to use kind of the results from these two groups to help inform goal-directed program improvements so we can best meet the needs of both the residents we serve as well as the medical students who participate. So to assess the public housing residents, we compiled attendance data since 2017. We also collected medical student field notes that were and reflections that were taken from 2018. We conducted 2 focus groups and 3 individual interviews of Highland Gardens residents, asking questions about motivations, barriers. Oh, and did my screen stop sharing for a second? Or is that just me?
Yeah, no, it did go black on our end too. So
no,
it's back.
Okay.
It's back.
Okay, there we go. Sorry. So we did 2 focus groups and 3 interviews, asking questions regarding motivations, barriers, and benefits for attendance, as well as areas for improvement. These were all transcribed and coded using pre-identified codes via multiple coders. The process for assessing medical students was very, very similar. We compiled a list of medical students who had served in a leadership position in the program. Since its initiation, we conducted 6 interviews asking reflective questions about participation and any potential impacts on both themselves and their careers. And then these were also recorded, transcribed, and coded in a similar manner. So in regards to our results regarding the public housing residents, we documented that 45 distinct residents have been in attendance since January of 2017. They attended on average 5 sessions, and there was an average of about 10.8 residents who attended every session that we've held. Analysis of our qualitative data revealed 4 primary themes: a desire to learn, dedication to helping others, generating a community, and frustrations with healthcare. We also assessed for barriers to attendance, which were primarily personal obligations like work or doctor's appointments, or simply just a lack of interest in the topic itself. A lot of the residents also speculated about why other people might not be attending the sessions, and this was primarily attributed to a sense of laziness or speculations about laziness regarding one's health. And then the last thing we asked was about areas for improvement, which primarily were either increasing activities in the presentations or improving advertising. In regards to assessing the medical student leaders, we identified 9 total graduated medical student leaders, 6 of whom participated in our study. The typical length of participation in the program was anywhere from 2 to 3 years, which is in alignment with pathway involvement, as most people found out about the program through the urban and community health pathway. And of those 6 individuals, 5 individuals are currently internal medicine practitioners of various subspecialties, and 1 is a pediatrician. So our analysis of these interviews revealed 5 primary themes: improving communication skills, getting to see healthcare in a community setting, building positive relationships with the residents of the apartment complex, and it disappeared again, fostering a love of community work, and then just kind of this notion of feeling like you're making a difference. In terms of areas of improvement, very similar to the residents in incorporating more activities, but they also suggested further collaborating with specialists, faculty, and other healthcare professional students, such as dental students. So in sort of a brief touching on limitations of our study, we kind of did have a generally low number of participants in both groups. 45 residents have attended the sessions, but only 11 participated. In regards to the medical student leaders, we just had sort of a small pool to pull from in the first place with only 9 individuals. Obviously indicating that some voices might not be represented in our data, and in both populations running the risk of both a social desirability and a selection bias. Overall, though, the health education at Highland Gardens program appears to be positively impacting the residents, the apartment complex. The program appears to have both a mental, social, and emotional benefit to them beyond simply providing health information. And it also seems to us that this program provides a very safe space for members of marginalized communities to be able to interface with healthcare professionals. For the medical student leaders, the program allows students a space to be able to kind of clinically applicable skills like communication, but also provides an opportunity to foster understanding, appreciation, advocacy, and admiration for at-risk communities. And that's all I have.
Great, thank you. Well, we have time for a few questions. I'm curious if you could comment a little bit more on what were the structures of the presentations, and were there any recommendations for keeping people engaged, and kind of how the topics were selected?
Yes, give me 2 seconds. Sorry, I just wanted to make sure I wasn't sharing my screen anymore. So presentation structure, sorry. So generally speaking, the medical students who run the program kind of get to dictate the structure of the presentations as it currently runs. People usually, the residents will pick a topic, the students will develop an outline, develop a PowerPoint, and the PowerPoint will usually include lots of discussion, questions, potential activities involved, and then a lot of the times interactive handouts as well. And I apologize, I totally missed the second part of your question.
No worries. The second one was, how are the topics identified?
So we try to, rather than assuming what topics the residents want to learn about, we always ask them what they would like to learn about. A lot of the time, the topics are generated from personal experiences. People have diabetes and they want to learn more about it, or someone's friend got diagnosed with cancer and they wanted to learn more about that during flu season. People always want to learn about vaccines. So we find that the topics typically get drawn from personal experiences.
Great, thanks so much. Let's make sure to give her a round of applause. Excellent presentation. Next up, we've got, I think, Brian Johnson or Sarah O'Connor.
Yes, I'm going to be presenting. Let me just get my screen shared. Can you see that okay?
Yep, looks beautiful. Go ahead, take it away, Sarah.
Okay, thank you. Good afternoon. I'm Sarah O'Connor. I'm a program manager in the MCW Office of Community Engagement, and I'm presenting this poster on behalf of Dr. Brian Johnston and our team. Research shows that medical professionals are more likely to meet the challenges of societal issues when they understand community engagement. Community engagement is defined by Carnegie as a collaboration between institutions of higher education and their larger communities. And this collaboration is for mutually beneficial exchange of knowledge and resources, which all occur in the context of partnership and reciprocity. It's critical that medical education is infused with community engagement in order for future physicians to understand social determinants of health and to address health disparities. The Office of Community Engagement collaborated with the Medical Student Summer Research Program, also called MSSRP, to offer a broad community engagement didactic session and a focused community engagement immersion program. Since it was in 2020, the program was virtual, and the summer immersion program built on our office's prior community engagement roundtable offerings for medical students. The 153 MCW M2s who participated in MSSRP attended a required 1-hour community engagement didactic session that we offered both as a broad learning opportunity and also as a way to recruit students who are interested in delving further into community engagement. These MCW students, as well as medical students from University of Nebraska Medical Center, were invited to submit applications for a 3-session summer immersion program. 30 students applied to and participated in this immersion program. There were 13 from MCW and 17 from UNMC. 3 1-hour immersion program sessions were then held virtually during the summer of 2020. Each session included a focus on specific principles of community engaged research presented by MCW faculty and their community partners, and also included time for facilitated small group discussion. Community engaged research is a core element of any research effort that involves communities. It requires academic members to become part of the community and community members to become part of the research team, thereby creating a unique working and learning environment before, during, and after the research. Sessions focused on principles including equitable power and responsibility, strong community academic partnership, capacity building, and effective dissemination. Post-session evaluations then asked participants to provide feedback. The results indicated that 153 students, which is approximately 75% of all M2 students at Milwaukee, were exposed to the initial community engagement didactic session. Surveys assessed whether respondents found the session worthwhile, the 3 immersion sessions worthwhile on a 5-point scale that ranged from strongly disagree to strongly agree. For all 3 of the small immersion sessions, at least 90% of respondents strongly or somewhat agreed with this statement. Using the same scale, the survey assessed whether respondents learned something that they thought they will use in their practice or profession. And for all 3 sessions, 100% of respondents strongly or somewhat agreed with this statement. At the conclusion of the 3 immersion sessions, 40% of participants expressed interest in continuing their learning via a community engagement journal club, which is currently happening with Dr. Brian Johnston and Dr. Leslie Ruffalo. Several participant comments that represent comments provided throughout the program are shown on the poster. In conclusion, we believe it is important to offer medical students an opportunity to learn about community engagement and to engage with other medical students, faculty, and community partners to further their learning. We believe there's demonstrated interest from medical students to learn about community engagement, and we will continue to try to offer broad and deep opportunities for engagement in this area. On behalf of the team, I would like to acknowledge Dr. Ramani Ramchandran and Ms. Shamia Gary with the CTSI MSSRP program for their collaboration. And I'd also like to acknowledge the community and MCW partners with whom we implemented this program. Thank you.
Great, thanks so much, Sarah. Again, if anybody has any questions, please add them to the chat. So I do see that in your bubble that part of the value was having some of those guest speakers from the outside organizations. Can you comment a little bit on how you used community members as teachers in this during this program?
Sure. So for the 3 immersion sessions, we had different community engaged faculty who co-led with a community partner who they had experience with. So for each session, the partners focused on a different principle. So whether it was effective dissemination or equitable power and responsibility, there was always a conversation that was demonstrated to all of the students between the faculty and the community partner.
Great. Well, let's thank Sarah with our clapping reaction. You can give her a different one if you want to do the party one or the thumbs up. I like that too. So we've got, last but not least, I think is Morgan Ashley Craft.
Yes, hi, I'm here. Let me just share my screen. Alrighty. Can everyone see that okay?
Yep, looks good.
Okay. Hi, I'm Morgan Ashley. I'm a 3rd year on the Milwaukee campus, and I'm presenting the tiered mentoring at JMAC. It will be an evaluation of a medical student-led health careers outreach program. So just as a background, only about 7% of recent medical school graduates are African American and 4% are physicians, which does not reflect the US population. So it is believed that if there is an increase in the racial and ethnic backgrounds or diversity of backgrounds of physicians, that it could reduce the health disparities seen in underrepresented groups. So pipeline programs were created by medical programs and other institutions to target underrepresented youth and increase their exposure in the healthcare field. So through the pipeline program specifically ran by MCW, we had 3 main goals, which was 1, to increase the high school students' knowledge of healthcare careers and post-secondary education. We also wanted to increase their exposure to summer enrichment programs so that they can get a better understanding of healthcare careers. And it could also help boost their application when they decide to apply to college. And we also wanted to use the sessions to increase their cultural awareness and their abilities in intercultural communication. So this was done through the Youth Health Service Corps that is based out of the Milwaukee Area Health Education Center. So we serve the James Madison Academic Campus, which is a Milwaukee public high school that predominantly serves African American students that come from disadvantaged backgrounds. And the MCW students that participate in the program were mainly based out of the urban and community health pathway, even though it was open to the entire school. So for the 2019 through 2020 academic year, we had 15 JMAC sophomore through senior students enrolled in the Youth Health Service Corps. And these students already had like a baseline interest in healthcare careers, and they just wanted to explore it further. And each session consisted of about 3 to 5 MCW medical student volunteers. So the sessions were hour-long, they were healthcare focused, and they were topics that were based on the student interests. We also had a service learning aspect that incorporated the Milwaukee Firehouse Department, in which the students were able to collect the amount of automated external defibrillators throughout Milwaukee. So it gave them the opportunity to work in a team and to also be exposed to the importance of AEDs, the importance of like the first response team. And we were able to implement a field trip out of that, as you can see through the picture right there through the Firehouse Department. So each session was evaluated through pre and post surveys. So we were only able to implement 5 sessions during the school year. Due to COVID, we could not finish the last 3. Our attendance went down, which I will later talk about how that was a challenge for us, but the satisfaction amongst the students did go up. And also we found that the sessions that were a little more hands-on, such as career planning and the summer program session, which we gave them one-on-one attention, was rated the highest as far as their learning. So as I mentioned, some of the challenges that we faced, for example, we had limited access to technology. So we wanted to research summer programs with them, but sometimes we didn't have access to computers. So we had to work creatively. It was also difficult for us to create an intimate environment with the students because we had limited MCW students and we were also outnumbered. But we did try to combat that by breaking them into small groups so they can have that one-on-one attention. And of course, due to COVID-19, we weren't able to finish out our sessions, and we also lost communication with not only the students, but also the teachers at JMAC. So that was difficult for us to at least get the post surveys to see how the students felt about the entire year as a whole. So for future directions, we are right now this year doing it completely virtual. So our goal was to continue field trips. So now we're going to do virtual field trips, which I know a lot of places are transitioning to that. We also want to do some type of earlier implementation of the service learning project. But since we're at the beginning of the school year, we're transitioning to virtual. We haven't been able to gauge what service learning project the students want to do yet, but that is a goal of ours to start that this year instead of the second semester. And of course, we want to engage new cohort of medical students and collaborate with JMAC as far as adapting to our new normal. So to finish off, I would like to add a special thank you to Dr. Moyer and Ms. Suzanne Letelier just for their support for both myself, the MCW students, and also the students at JMAC.
Awesome, thanks, Morgan. So we have time for questions. Maybe you said this again, it's the 8th talk, but how are the students identified that participate in the program?
Right, so there is a specific science class that the students are recruited out of. And then we also encourage them if they have any type of friends that don't happen to be in that class and they think their friends may be interested in the program, then we encourage them to invite them. So we never turn away a student. We just try to get them to increase their exposure. Even if there's a small inkling of student who may, at the time when we were in the building, may pass by and ask what's going on, we would ask, tell them to join in the session and see if maybe it's something that they wanted to do long-term.
Yeah, awesome. All right, well, let's everybody choose your favorite reaction for Morgan to end out this session. I think, again, this was very exciting for me to hear all the great work, especially that our students are doing and being part of an institution that's really, valuing community engagement.